Excellent. So, well, let us struggle with the technology, but also try and start and go ahead. If there are any hitches, we'll take them as we go on. I want to welcome everybody to the call this afternoon. It's more than a call. It's a webinar. And to thank you all for being available at this very difficult and challenging time all over the world. I don't know what situation you are going through individually or as organizations or as countries, but I know definitely it's a very challenging time. So within that context, we thought that we should still continue and do the webinar today, which initially, this is something that we should have done at the WHA, which usually a face-to-face and physical meeting, and usually longer than what we have planned today. So it is going to be rather tight, considering that this is a meeting we had planned to do over 3 hours, and now we're going to try and do within 1 hour. I'm very sure you're all capable of working together so that we make this a reality. I want to thank in particular our team and our partners from the WHO with whom we have worked not just on this webinar, but in the last few years, our collaboration has become even stronger. And that is the presence of Dr. Rudiger here today as our keynote speaker is definitely testimony to that. So welcome. I'll not make a lot of general points, but just to say that we thought that even as we go through COVID and these unprecedented times, we should still have an opportunity to talk about where we are going with health promotion in the future. So that is the framework within which we have the webinar today. We're looking at the situation we are in today, but also thinking about where might we be going going forward. And that's why we have within the theme the idea of beyond COVID-19. Otherwise, this seminar or meeting was initially to focus on how health promotion could play a greater role to achieve SDG3. So that remains there, but this is the overarching structure or architecture within which we have the seminar today. We'll, as I said, we don't have very much time, so it's now my pleasure to call upon our first and keynote speaker, Dr. Rudiger Kresch, who is the director of the health promotion department within WHO. This is a department or a unit which has grown in size and stature and recognition and roles and responsibility and authority within WHO. Dr. Kresch, please welcome.
Thank you very much, Bernard. Thank you very much, Gabriela and Michael, Mihaly, for this very kind invitation. And Bernard, thank you very much for your kind introduction. It's really, dear colleagues and friends, ladies and gentlemen, it's really a true honor for me to address the future of health promotion at this webinar today. Health promotion has been a driver for public health for many years. Just think of our action areas, such as building healthy public policies, in which today's language we refer to as health in all policies, or our approach to community engagement and participation, which are truly in our DNA, and our efforts to reorient health services so that health professionals are the best advocates for creating societies in which healthy choices become the easy ones. The COVID-19 pandemic is perhaps the last wake-up call for the world to understand the importance of health for the way we design our societies. Some economists estimate the overall costs as of today at $6 trillion, which are 2/3 of annual global GDP. We now see that health impacts all walks of our lives. Health impacts mobility, trade, the service industry, banking and finance, employment, our social life. And we start to understand how fundamental this global societal disruption is if health impacts of policies are not considered. It would be a huge mistake if the world would not learn from this crisis and fundamentally address existing weaknesses. Other crises, such as H5N1 12 years ago, H1N1 10 years ago, and Ebola 5 years ago, could have as well served as wake-up calls. Unfortunately, the world reacted with relatively small adjustments. The recommendations of a range of expert committees that unanimously called for health in all policy approaches to assess health impacts and risks that could lead to future outbreaks were not implemented. I had the privilege to serve as the lead of the WHO Secretariat of the Review Committee of the International Health Regulations in 2015, and saw firsthand how united researchers were in their assessment. Health promotion can be a driver in a fundamental review of how societies can be redesigned to address both sides of the same coin. How to prevent risks that would lead to a next pandemic, and how to create a world where all people enjoy healthy lives and well-being, living a healthy, safe, and supportive environment as members of an inclusive society. So you've asked, what are the core dimensions of future health promotion? Firstly, let me say how valuable our work is on health literacy, global health diplomacy, our work in creating health in the settings of everyday life, such as healthy cities, health promoting schools, enterprises for health, healthy regions, islands, and prisons. Health promotion is pivotal in the work with vulnerable population groups. And let us not forget that we paved the way for the work on social and commercial determinants of health. Just look at the definitions. And for universal health coverage. There has been tremendous learning in our work. For instance, we understand today that what we called prerequisites for health in the Ottawa Charter can be influenced and are not unchangeable conditions and resources that need to be in place before health promotion action can be successful. We understand today that we need to be centrally involved. We learned that peace, shelter, education, food, income.
What is a matrix? So matrix is the arrangement of numbers or arrangement of items.
Sorry?
Rows and columns.
I think somebody needs to put himself on mute there so that I can continue. Thank you. So let me restart. I think we understand today that we need to be centrally involved in those prerequisites for health. We learned that peace, shelter, education, food, income, a stable ecosystem, sustainable resources, social justice, and equity need and can be influenced by us. There has been tremendous learning in building social environments. People need people. Health promotion is based on this social support. The way we design health promoting settings has at its core that social interaction is fundamental to good health. we could learn from this right now in the COVID-19 response. We see the huge mental health problems that are occurring, and we also see heartwarming signs of solidarity across the world. What does this mean in today's and tomorrow's world? The potential of reorienting the health system is enormous. At least 50% of the global disease burden could be prevented through ensuring healthy environments, safe and supportive societies, and investments in disease prevention and health promotion to ensure healthier lifestyles and reduced risks. Unfortunately, this potential is not realized by global health investments. Investments in broader population-based disease prevention and health promotion programs are underfunded, even though they yield high returns. For example, WHO's best buys for NCDs include cost-effective policies to reduce tobacco and harmful alcohol use, address unhealthy diets, and increase physical activity, even though they provide returns on health many times over. Just $1.27 per capita, these interventions could be scaled up to reach 50% of people in low and middle income countries, yielding a return of $7 for every $1 invested. Access to improved sanitation is another example. It provides a return of $5.50 per $1 invested, and yet some 2 billion people worldwide lack access to basic sanitation, while diarrheal disease remains one of the biggest childhood killers. Increasing spending on prevention and health promotion, with a focus on cost-effective solutions, will help to improve health outcomes, reduce healthcare costs sustainably, and contribute to broader social, environmental, and sustainable development goals. Ensuring health and well-being in the 21st century requires us to address health in the context of the major global transitions in demography, urbanization, energy use and climate change, food systems and nutrition, epidemiological trends, and rapid technological change. In addressing these transitions, we need to be proactive, not only mitigating risks after they occur, but also proactively bending the curve of trends to reduce health impacts and optimize co-benefits. Just as an example, in developed countries, some 50 to 70% of people with internet now go online as the first point of health information in developed economies. In developing countries, smartphone ownership stood at 42% in 2017, and social media use continues to rise. Artificial intelligence and digital health can serve as important tools for improving data collection and triage, training, predicting future health events and risks, as well as behavior change. Nevertheless, privacy concerns are also a key digital health issue, and social media can have negative impacts on mental health. There is vigorous debate over the safety of some new technologies, such as 5G telephony, while e-waste created by throwaway technologies constitutes a growing environmental health threat among the poor of the world's sprawling cities. Clearly, these transitions are all closely interrelated, as are the economic, environmental, and social systems that underpin the way our societies function. And these transitions all have both positive and negative health impacts. As a health promotion community, we can actively support policymakers who design the legal marketing and trading frameworks for goods and services, what is healthy and what is not. In disease prevention, we often tell people what they should not do. Don't smoke, drink less alcohol, eat less sugar and less fat. In WHO, we are actively supporting pension funds from disinvesting from tobacco, We are working with the governments to raise taxes on tobacco, alcohol, and sugar-sweetened beverages. We are working with governments to ban tobacco advertising, limit alcohol sale, and negotiate with soft drink companies to lower their sugar concentration in their products. Colleagues, in disease prevention, we are often spoiling the party for many investors who want to make a quick buck. But going forward, we need to throw a new party. In health promotion, we are looking at the things that positively influence population health. For example, sovereign wealth funds, pension funds, and impact investment funds collectively manage about $52 trillion in assets. Allocating a portion of these investable funds to investments that positively impact health will certainly contribute to healthier populations. Identifying those investments that are good for global health helps to reduce the currently high costs for individuals, families and communities, society, the economy, and the planet that occur through current investment policies. Going forward, we will be engaging multilateral development financial institutions, the private sector capital markets, and the banking community to ensure that borrowers adhere to activities that promote health and well-being. For example, large infrastructure projects are currently not done with active transport, such as walking and cycling, and road safety in mind. Using fiscal and legal tools, one can develop a system of incentives and disincentives with appropriate risk-sharing arrangements to encourage health-promoting lending policies and practices. Going forward, we will be engaging regulatory authorities, including banking and securities regulators and investment authorities, in sustainable pro-health market shaping policies. We will assist them to provide regulatory incentives and disincentives to entities under their jurisdiction that will promote health. This includes providing regulatory incentives to the institutions that have a positive impact on the common good. For example, investors that comply with environmental, social, governance, and health criteria. Banks that lend to health-promoting industries would be subject to lesser regulatory reserves. Environmental regulation would be structured such that the true costs of environmental impact is reflected in the costs of a project, including the application of the polluter pays principle. Fiscal incentives, such as subsidies or tax breaks, would only be provided to health-promoting industries. Going forward, we will be engaging partners to advocate for corporate governance reform, to make the board more accountable for actions that impact on public health. Multinational corporations are amongst those selling health-harming products and should be made more accountable for their actions. WHO supports those corporations that move away from a shareholder-centric position to one that takes into consideration other influences, such as population health gain. While we acknowledge that this is a very different way to look at business, business leaders increasingly see the value that stakeholder value offers huge potentials to drive very different strategies and outcomes. Emphasis on short-term financial returns should be discouraged of more long-term returns, which complies with the ESGH, so the environmental, social, governance, and health criteria. Going forward, we will provide fiscal and legal technical support to member states considering fiscal measures and other pro-health market shaping policies affecting health. The provision of subsidies or tax breaks for health promoting activities such as sustainable transport, exercise and sport participation, as well as the consumption of fruits, vegetables, and healthy diets, offer tremendous opportunities to help consumers make the healthy choice. WHO supports initiatives to remove subsidies for fuels as well as those activities which harm the environment. The aim of this support is to provide an enabling environment to make the healthy choice the easy one. Finally, we continue to engage partners to promote collective action for health and well-being. An empowered citizenry is essential for people to enjoy the highest attainable standard of health and to make governments accountable for the health of their people. WHO will continue to engage partners in health literacy, strengthen participatory governance and health in all policies in support of legal and fiscal measures affecting health, and help ensure that informed consumers support an enabling environment for healthy choices. Dear colleagues, health is a compass for development and a barometer for a nation well-being. As money makes the world go round, we need to address main financial flows. To create a world that is better preventing a new pandemic to disrupt the world, the risks and their conditions need to be addressed. To develop a healthy economy, we can and must be supporting the industry and enable them to make the healthy choice. I thank you.
Well done. Thank you, Dr. Kresh, for that very solid and comprehensive presentation. I'll now ask Dr. Mihaly Kokenyi, who is former Minister of Health in Hungary and also a big friend of the Alliance and health promotion, and also a technical advisor to the Alliance, to respond to your keynote address. Dr. Kokenyi, welcome.
Thank you very much, Bernard. I hope that I can be heard. Greetings from Hungary, Budapest. I try to be very brief because Rüdiger provided with a wonderful overview on the role of health promotion during the pandemic and beyond. I have some minor, mostly accessory and amplifying remarks to share with you. First of all, there are plenty of lessons for the world to learn and perform much better than during the previous epidemics. Health promotion and health in all policies cannot remain on the wall as thrown up piece, because if people's health literacy is missing, the resilience of communities will be weak. If this case continues, the impact of public health messages will be insufficient and societies will be more vulnerable to the disease and also to undesired political intentions. We must not forget the Ottawa Charter, in which, if we read it again and again these days, we'll find in it almost all the important things to do. So there is an urgent need, dear colleagues, for people to regain control of their health, to protect themselves against the disease, and to deal with its disruptive consequences. Second, we need to think in a broader perspective. Of course, the classic settings are not negligible, but as we stated at the 9th Global Conference on Health Promotion in Shanghai, much of health promotion today, whether we like or dislike, is global and political. Challenges of today, such as unsustainable lifestyle and consumption patterns, accelerated flow of people, and others, are determinants of our health as well. These factors are closely linked, is what first Ilona Kickbush called the political determinants of health. These have been highlighted as one of the 3 overarching recommendations of the Commission on Social Determinants of Health in 2008, just to remember what are called tackle the inequitable distribution of power, money, and resources. I don't have to argue how timely this is. Thirdly, as regards funding, I think Rüdiger was completely right. Increasing investments in public health and finding innovative solutions also at global level, different from the national budgetary sources, are key. This needs to be openly debated in times when the global health architecture, the role of the WHO is revisited. Fourth, and finally, about civil society. Experience with the way the Ebola epidemic was responded to in African countries, as well as the current pandemic response in countries like Germany or New Zealand, showed that in an environment of trust, community partners can help to improve the understanding of disease control protocols and suggest moderate changes that better reflect the community's sensitivities without compromising safety. International NGOs such as the Alliance can do much to build a new effective global health collaboration by channeling these community experiences. Having said this, I would like to thank you for your kind attention and wish you a virus-free good health to all of you. Thank you very much.
Thank you, Professor Kokenyi. Again, really enriching and contributing to the very solid presentation by Dr. Kresh. And you brought us to the point where I'm very glad number 4 is on civil society. And our second part, or the next part of our presentations, will be from civil society, just to see a bit of what they have done or what they could do, and then to see what lessons could we learn from what they have done going forward. Let me just remind everyone that if we have any questions, just type them out in the chat box, and we will take them when we have a good number. I see we have 2 questions, but they're rather complex and not so direct or easy to answer. So I still suggest that if we continue a bit, hear what civil society has been doing, we might get a chance to round up the different questions. But please do send them into the chat box. Thank you, Dr. Kokenyi, and thank you, Dr. Kresh. I'll now invite Professor Elizabeth Cherian from Lakeside Health Promotion Center in Bangalore, India, who will tell us a bit about what they have been doing during this COVID season as a civil society organization. Elizabeth Cherian is the Vice President of the Alliance for Health Promotion, and she is also the President of the Rotary Club of Bangalore in India. Welcome, Elizabeth.
Thank you very much, Bernard. Am I audible?
You are.
Thank you so much. I'm speaking on civil society as game changers for the COVID-19 impact crisis. To begin with, India's lockdown started on the 24th of March midnight for 21 days, followed by an extended lockdown 2.0 for 2 weeks until April 30th, and an extended further 3.0 by 2 weeks until May 17th. The fourth, 4.0, is set to begin from 18th May. There will be probably an easing of guidelines the states have been given the liberty to make individual changes to the national norms as necessary based on local case scenarios. The case updates as on 15th May 2020, 8 a.m. from the Ministry of Health are on the screen for you. So you will see here on the screen that India has got a total of 79,320 cases, and the discharged cases are 27,919, deaths 2,649. Coming to the state where we live, Karnataka, we have a total cases of 987, recovered are 460, deaths 35. Kerala, you will see, is a small state of South India, which had 560 cases, 491 recoveries and 4 deaths. Maharashtra tops the list with 27,524 cases, 6,059 recovery and 1,019 deaths. Gujarat comes next, 9,591 cases, 3,753 recovered and 586 deaths. Now, India is testing at a rate of 1,264 per million. Kerala is a success model in view of the fact that they responded earliest and had the highest testing rates in the early stage and ensured strict adherence to the lockdown norms. Proactive leadership with NGOs augmenting the services of the government, which went on to even include full-fledged ICUs for COVID-affected patients, were significant. Bangalore, our district in the state of Karnataka, has a population of 12.34 million and India has a population of 1.38 billion. Bangalore, considering the magnitude of the population in Bangalore, it was certainly obvious that this was an opportunity for civil society and NGOs to earn public trust and plunge into action. The magnitude of the impending COVID crisis made it clear that without the engagement of civil society and NGO partners, efforts would be highly inadequate and there would be huge gaps. This now is a story of how NGOs brought communities together for collective action and were able to voice concerns at local, national, regional, and international levels. You will see now that civil society has actually acted as a game changer of the COVID-19 impact crisis. Next, can we go on to the next, please? Katharina, can we go on to the next slide?
I think since Elizabeth, we have so many participants, we are very popular today. It might take a little bit of time for the slides to load when it changes. Sorry about that.
Okay. So please continue to change as I go on. Anyway, the slides as they come on, you can see that we went on to decide how we would want to help society during this crisis. So the grocery kits, we distributed grocery kits to children and families of free schools whose parents are daily wagers with no income during the lockdown. We did this because these children come to school only for their free midday meal and for a glass of milk that they get in the whole day. We knew that the lockdown will affect them the most. Hence, we took it on ourselves as an NGO to distribute free grocery kits to children and families whose parents are daily wagers and whose income was totally blocked during this period. The next thing that we thought of is to feed the stray animals. We have quite a few of them, like cattle, dogs, cats, birds, etc. So we had to do something to feed these animals. We went around in a van that was donated by us to the CUPA. CUPA is an organization called Compassion Unlimited Plus Action. And so we went on to distribute food to these stray animals with the permission of the police. What needs to be known here is that it was a great challenge to get these things organized during this lockdown period because we had challenges of making logistics possible. We also distributed what we call masks for all the people of a Home of Hope. Home of Hope is an organization in Bangalore which caters to the poorest of the poor, those rejected totally by society. And we distributed masks to all the inmates. There are about 750 inmates who already have other underlying conditions and who are at a great risk of contacting COVID infection. Therefore, we distributed masks to all of them and ensured that we also serve cooked meals to the inmates of this home. This means we had to distribute about 1,000 meals every day during the entire period of lockdown. We also were supported by the media. The role of the media was very significant during this time. The role of media was especially important because we had to combat fake news and fear mongering. The local newspaper joined us, and every day of the lockdown, it carried a message which was positive, which was relevant, and which was accurate for people to understand, to keep away from fake messages. Next, we went on to distribute PPE kits to hospitals, police, bank staff, and municipal workers, because we realized that there was a shortage of this equipment during the lockdown. This again went on to a big way that they were able to serve society because they could get these equipment on time. In addition, we had to appreciate these people who were doing emergency services without caring for their own health and taking the risks. So we gave them all certificates of appreciation to the staff in hospitals, to the municipal workers, to doctors, NGOs, and CSR partners. There was an article in one of the magazines of India which said the NGOs fed more people than the government did during the lockdown. There is a slide here which I don't know if you will be able to see during this talk or later, but it has a graph which clearly indicates the role of NGOs versus the government. Believe me, the government could not have reached the number of people that NGOs managed to reach during this time. There is one important slide that I would hope that you will see before I conclude. That is a COVID support dashboard. The donations that we made towards the COVID-19 relief between two NGOs was US $265,000. The total volunteer hours spent on assisting the government was 12,400. Medical kits that we distributed was 2,800 plus PPE kits. Cooked meals served. We served about 1,500 meals every day for 30 days. Dry grocery kits, 3,000 plus kits were served. The lives that we touched during this period are 12,000 plus life through grocery and 1,500 through the cooked meals alone. The animals that we cared for range from 2,500 up to 3,000 animals. The total COVID contribution to a PM Care Fund through our organizations across India is 105 crores, and our district alone has given 12 crores to this fund. So these are what we actually did during the COVID relief time. What was important here is that NGOs became COVID-19 counselors, happiness volunteers, and the caring and the compassionate arm of the governments. They reached where the governments could not. We need to be positioned to respond to crisis and initiate steps ahead of time. It is time we ensured that every last person is assured of basic health care. Our vision of love and compassion must live on, and the fire of enthusiasm to act at local and community levels must rage on long after COVID-19 dies down. Protecting nature and arresting environmental degradation is our responsibility and must become a global priority, a lesson well learned during the current crisis. We need to reinvent preparedness strategies from time to time and at a rate much faster than before. The action of civil society in times like these are what will ensure our relevance and define our role in any future crisis. Together we can. Thank you very much.
Thank you, Elizabeth, and very clear as to the possibilities and realities for civil society to contribute to health, but in this particular case, in terms or in times of a crisis or in terms of an emergency. So thank you very much. We'll take this again together with the other presentations. Now, it's my pleasure to invite Eric Friedman. Eric is from the Global Health Institute, and he is the Justice Scholar at the O'Neill Institute for National and global health law at Georgetown University in Washington, D.C. During this inequity or human rights issues have always persisted in light of health, but even in general development. But now this might take on a new line or a new color or a new depth, or even be exacerbated during a time of a pandemic. So Eric Friedman, please speak to us about human rights, inequity, and equality in times like this. Welcome.
Thank you very much, Bernard, and thank you for having me here. So I want to just talk briefly about, as Bernard said, health inequities and human rights, how they've manifested themselves during this pandemic, and then offer a proposal at the end of how to prevent or limit such injustices going forward. So just a brief overview of several of the health inequities that we've seen during COVID-19. I'm, as Bernard said, from the US. Looking here, we have by far the highest rates of infections and deaths among poor and minority populations, Blacks, Latinos, Latin Americans. Also some of our really most marginalized populations, prisoners, where there have been cases, for example, of prisons where 70% of the population has been tested positive for COVID-19. Group homes, or homes for people with developmental disabilities in New York, 5 times higher the rate of infection and death than the overall population. So it's sort of what we know about health inequities, that they're there, but we're really seeing them now. Some of the reasons for these are more underlying health conditions like asthma, diabetes, and heart disease, access to healthcare, tattered housing. This is certainly far from only a US experience. In the UK, much higher death rates among people of color. In Singapore, considered a success story until it turns out they neglected to protect migrant workers, of course, sort of most marginalized population there, and cases exploded after that. Globally, we have the same picture where the greatest threats, both from COVID, but very much also the socioeconomic effects, are in many of the world's poorest countries. For example, in the US, we've had huge ventilator shortages, but if you look, there's a study, 41 countries in Africa, less than 2,000 ventilators between them. Death toll fears that could reach millions in poor countries, and risks of huge numbers of people experiencing acute hunger and extreme poverty. What does this have to do with human rights violations? Well, human rights violations underlie all of this. For example, domestically, looking at lack of access to healthcare despite the right to health, lack of access to nutritious food despite the right to health, right to food, and so forth, clean water, same story. Outright discrimination, where poor communities of colors are where polluting industry, transportation, with a lot of pollution are located, leading to higher asthma, for example. And then pandemic preparedness that we've seen throughout have not paid attention to these more neglected, marginalized populations, contributing to the terrible disproportion of inequities that we see with COVID. Globally, countries often don't have the accountability mechanisms to ensure that health systems conform with human rights obligations. Health services almost everywhere are not accessible to everyone, despite the right to health and the requirement that everyone have access. And looking at an international cooperation level, there's treaty commitments in human rights treaties, WHO treaties like the International Health Regulations, UN Charter, and other UN treaties on things like international cooperation and assistance, and yet we've seen a huge paucity, a huge lack of that. So one proposal that we have to address this is what's called the Framework Convention on Global Health, long-standing proposal, more than a decade now, that really takes on, I think, a special important and relevance, and hopefully one that becomes very clear in light of COVID. Very briefly, its mission would be to achieve accountability to the right to health, and its aim would be national and global health equity. It would have three core baskets of activities, of stipulations, goals. One would be to implement key human rights principles of accountability, participation, and equality. A second would be to resource to fund the right to health in terms of funding, but also other resources like healthcare workers and other health workers. And third, it would aim to ensure the right to health across all actors, including private, public, and private, and all sectors. In other words, a true health in all policies, social terms of health approach, with action ranging from the local to the global level. And so how would FCGH have reduced the inequitable effects of COVID-19, and how could it do so for anything like this going forward? And more generally, I'll give three quick examples before closing up. One is that it would require right to health impact assessments. How would different projects, policies affect the right to health in different communities? What would happen if you did this and followed these assessments? That would mean you cannot disproportionately burden marginalized communities with polluting infrastructure and thus reduce asthma, one of the underlying conditions that leads to deadly complications from COVID, and surely itself potentially deadly, and in future outbreaks of huge concern. It would require participation, including of marginalized populations in health-related decision making. To just give one example of what this would mean, it would mean urban design that contributes to health, physical exercise, green space, for example, easy access to nutritious food, improving lung health, heart health, reducing diabetes, reducing, again, the underlying conditions that we see contributing to increased death from COVID-19 and hugely and contributing to increased death and disease, of course, outside COVID-19. And third, it would include multiple mechanisms for accountability and require transparency. What would this lead to? It would mean more effective health spending, more equitable health spending, which would mean equitable and universal access to healthcare. Again, one of the issues that we've seen and problems with the COVID-19 response and complications, but in general needed for healthy living. And so we view, and I encourage WHO and others to look towards the Framework Convention of Global Health as part of the reformed post-COVID-19 global health infrastructure. You can learn more at the website of the Framework Convention on Global Health Alliance, which promotes the FCGH, at fcghalliance.org. Thank you very much for having me, and please stay healthy. Thank you.
Thank you, Eric. And just to mention that, as Katarina was saying, the webinar is heavily loaded, so it's not possible for us to run through the slides as they're presented. And just to let everybody know that we'll make all this material, including the recording of the webinar, available to those who have given their contacts, but also through our website at the Alliance. So I think this will be available for you to refer to. Thank you very much, Eric. And now I'll invite the students organization, IPSF, and I think in collaboration with the IMFSA, that's the medical students and the pharmaceutical students, to go through some practical ways in which the youth can be engaged in health promotion, especially health literacy, during a time of emergency, specifically during the COVID-19. So Hera and Omnia, please welcome.
Hi everyone, thank you for the floor. So I will be beginning with just talking briefly about the health promotion that IPSF has been going through over the past few months in regards to COVID-19, and then I'll pass over to my colleague Omnia from IFMSA, who will talk more about the health literacy. So to begin with, just to the next slide, if it'll go to the next slide. So to begin with, during the COVID-19 pandemic, it became increasingly aware that as a youth organisation for future healthcare professionals, IPSF needed to use its platform to educate and raise awareness to its members regarding the steps it needed to take to help reduce the spread of the virus. We encouraged our members to take local action where possible, but where not possible, we took to social media as it was a perfect way to disseminate information. We began by presenting a press release which mostly detailed the epidemiology of the virus, as well as the origin and transmission and basic information that we required, that we wanted our future pharmacists to be aware of when speaking with members of the public, or in general for our members to become educated on. Next. So after this press release was produced, we decided to have a global campaign which combined all 5 of our offices. And with this campaign, our main purpose was to show the impacts of COVID-19 all over the world. And so this campaign is something that is currently running right now. So I would highly suggest that you check out our Instagram page. So in the next slide, you'll just see a few shots of what our campaign has been up to. So we have been having different topics highlighted by different regions. So we've so far had APRO, the Asia Pacific region, which focused on the treatment aspect of COVID-19. And currently we have the PARO region, which is going through the student-led initiatives and highlighting the student-led initiatives. Just the next slide. So through our social media, we have managed to produce various different promotional posts. We found that social media was the best way to share basic information and also raise awareness for different areas of health that we think needed highlighting. So one of those was mental health. We found that a lot of students were struggling with mental health due to the transition of studying in person at university, then moving to online. It was a big transition for a lot of students, and it was something that we wanted to highlight and help with. So a lot of our initial social media posts were based on mental health and just basic hand hygiene, which we wanted the public and our members to be educated about. Next slide. So a lot of the other social media work that we took part in was with FIP, which is our partner organization, the International Pharmaceutical Federation. So with FIP, we were able to share guidelines that they produce. A lot of them were based standard operating procedures about how to function in community due to the virus, how to manage your staff, how to manage the pharmacy itself, a lot of basic information which wasn't really out there for the pharmacy profession. So we shared FIP guidelines. We also collaborated with FIP on numerous webinars, which is part of their ongoing series of webinars. And this again was on various topics. Some of them were on education, and some were just highlighting the work of people in different countries. Next slide, please. So as part of our global outreach, we had many local member organizations lead really important student-led initiatives. On the screen, you can see a few pictures. The one on the left is actually our most impactful outreach, which was our student members in Kenya who developed affordable ventilators. So this was quite a big achievement for our members in Kenya, and this was something that we really wanted to highlight. And then also on the right, you have pictures from students in Utah who were sewing cloth masks for local hospitals, and also the National Guard. The next slide. Here are a few more pictures. We had various different organizations throughout the world who participated in producing hand sanitizer in their local compounding labs at university. So this was quite a big initiative that we saw throughout all our members all over the world. Next slide. In regards to future work, as we make our way through this pandemic, we're still learning and finding out our way how to utilize health promotion during this time. As for many of us, this is the first pandemic in which we're able to actually contribute and find meaningful ways to do so. And so far we've learned that having collaboration with partner organizations, you can see some of the logos on the screen, are one of the main ways that we can continue to advocate and have our voice be stronger. We're also quickly learning that the impact of social media and elevating our platforms, ensuring that they become more interactive and engaging, allows us to have more of an impact and educate our members and help to share any important information that we have due to the limited in-person interaction that we can have. Thank you. I will pass over to my colleague Omnia for IFMSA part.
Thank you so much, and for the wonderful sharing of your incredible efforts. Hi everyone, I'm Omnia Al-Amrani. I'm a medical student from Egypt, and I'm the liaison officer for public health issues for the IFMSA, which is a federation that represents the voice of 1.3 million medical students from 129 countries. And we decided to, since the beginning of the pandemic, and as Dr. Tedros said, that we are not just fighting a pandemic, we are fighting an infodemic. That is why we decided to adopt and create an IFMSA COVID-19 health literacy response strategy. And we began by developing a designated page on our ifmsa.org website to streamline all our health-related and health literacy and information services. So in that page, we created a COVID-19 resource center that had all the different kind of infographics and information and guidelines in 7 different languages. And we also developed a list of all the national trusted websites for COVID-19 throughout all the countries and all our 5 regions. And at the same time, we created a standardized COVID-19 training presentation that we provided for all our members to conduct in order to increase the knowledge and the spread of the right information. And then we had a great opportunity to collaborate with the World Health Organization department that is responsible for health literacy and information management. And we created a survey with them to map all the different kind of fact-checking organizations and initiatives all over the world. And due to this contribution, we had the opportunity to present our COVID-19 efforts in their webinar that also had other youth leaders that were very active in COVID-19. And our survey has so far collected 170 fact-checking organizations so far, and we are still working on discovering more. And then we also had an additional collaboration with UNFPA and Prezi Video. As you all know, Prezi is a platform for slides, and we created with them a series of interactive information and awareness videos that can be recreated by anyone, by any member, any student or youth, or just it's very accessible to everyone to recreate this video using animations that we have prepared with UNFPA to spread the knowledge and the facts about COVID-19 to their families, friends, and communities. And you can also find this on the website that I shared here. And then we also decided to, since everyone is now in quarantine, we wanted to really build the capacity of our members, and we had the opportunity to collaborate even more with the UN Youth Envoy Office, as well as UNICEF, and we had representatives from IFMSA share their experiences for mental health related to the COVID-19 situation in their Coping with COVID series. We also organized a series of webinars with Amy to tackle medical education and its impact due to the pandemic, as well as another series of webinars with Yongo, which is the youth constituency for the UNFCCC, tackling the planetary health angle and its relation to COVID-19. And then we also had a designated page through our IFMC COVID-19 response page that has a map which tracks down the progress and how medical education has changed and has adapted to the pandemic. And you can press on each location and see which country, how did this country change their medical education, and this was reported by our medical students in our member organizations worldwide. We also had numerous opportunities to collaborate with educational platforms that offered our students a lot of packages in order to increase their methodology of using digital information and digitalized platform, for example, like Lecturio, like Insimi, like Ambos, and so on. And they provided lectures either specific related to COVID-19 in order to build their knowledge, as well as general access to medical lectures and so on that would help them study better as they are quarantined and in lockdown. And we also conducted global surveys to assess the medical education situation. In our resource center, we also had a folder that was designated for all our member organizations to share their activities, their local initiatives, and what they have done. We noticed that many of our member organizations developed their own national COVID-19 strategies, and they were very supportive in sharing it so that other organizations can be inspired and they can develop the same strategy. For example, in Morocco, they developed a strategy where they had goals and indicators to recruit at least 100 volunteers that can help with COVID-19 patients. And this was actually accomplished, similar to the national strategy that IFMC Iraq did. And on the other hand, we also have another folder that shared activities from 95 countries. All of them are student-led activities by our students, either awareness campaigns, training workshops, online, offline, as well as awareness videos. As you can see, these are medical students from different countries that have conducted these activities. So finally, to wrap up, now we have almost 95 country level activities mapped in our resource center and in our website. We also have established more than 20 global partnerships for our COVID-19 response efforts, specific to health literacy, as well as other different sectors such as medical education, climate change, and SRHR. We also mapped so far 170 fact-checking organizations and initiatives in collaboration with the World Health Organization to create a database for these organizations to be available for the populations and the communities to check out in a way to fight our infodemic. And finally, through our webinars and our social media campaigns, we reached over 10,000 outreach through that. I hope I wasn't too long. Thank you so much. And thank you for this great opportunity to present our student-led efforts.
Thank you. Thank you, Omnia and Hera, before that. So really amazing work. Both of you come from organizations that have a tremendous outreach, and potential is just remarkable. You reach almost or maybe everywhere in the world. So it's really very inspiring to hear what you've been doing, and also very refreshing some of the innovations that you bring up. Now, of course, we've run out of time. Some people will leave, unfortunately, but now I'll call upon Dr. Carlos Zacco, who is the president of the International Health Cooperative Organization and Espiriu Foundation in Spain. And Carlos Zacco will be talking to us about how to organize civil society in the face of a pandemic. We are in a country, we work separately or maybe together, and you get yourself into this situation. Let's hear from Carlos. Welcome.
Thank you, everyone. Thank you very much. Good afternoon to everyone. And thank you very much to the Alliance for Health Promotion for this opportunity to explain the Espiriu Foundation experience in this webinar. As you will know, Spain has been one of the worst hit countries by COVID-19. The first registered patient was known on January the 31. A state of emergency and a lockdown was imposed on March the 14th, and the peak of the infection there were more than 900 deaths daily. The ICUs were overwhelmed, and some hospitals were on the verge of collapse. So far today, we have more than 230,000 confirmed cases, more than 20,000 dead, and more than 145,000 healed. The SPRI Foundation, for everyone who doesn't know what it is a network of health organizations, COPs, caring for 2.6 million people, which is more or less 5.6% of the Spain population. It's made up of two main cooperative groups, ASISA and Asistencia Sanitaria, that act as an umbrella for a complex corporate holding made up of hospitals, medical centers, insurance companies, diagnostic units, user care centers, technology, and moreover. Some figures that may help you to understand the dimension and the impact of the whole group. In 2018, there were 30 million outpatient consultations, more than 400,000 surgeries, and more than 500,000 emergency services that the COPs done to the public. Under the economical point of view, SPRI network employs more than 6,000 people, which is of which 82% enjoys long-term employment and achieved a turnover of 1.6 billion euros the past year. Well, since the beginning, what has been the response of the SPRI Health COPs to the COVID-19? Well, in the beginning, we have to be cooperating with at all levels with our public health system. Nowadays, more than 9,000 COVID-19 patients have been treated in our cooperative facilities, where they had the priority because all non-urgent interventions and medical consultations were postponed. A new system of telemedicine and remotely delivered healthcare that embraces the benefits of digital technologies was launched instead. Hospitals were restructured their facilities and protocols, increasing the capacity in place, creating new intensive care units with a several-fold increase in some cases, reassigning professionals and hiring new ones. Regarding employment, SPRI facilitated to non-health workers working from home to protect their health and guarantee their safety. In healthcare area, additional medical and nursing staff have been taken on to meet the increasing demand. On the other hand, many medical doctors have seen their practice closed several weeks because of the lockdown. They have been unable to generate income to pay workers or invoices. SPRI COPs launched an aid program aimed to help doctors to handle these financial issues. The concern for the community is one of the main values of SPRI COP. In that sense, they created a specific free telephone advice service addressed to all citizens with a team of the organization healthcare professionals providing guidance and clarifying queries about coronavirus. We also launched the website ahora más que nunca tranquilidad.es, meaning keep calm now more than ever. It compiles helpful content concerning exercise, nutrition, mental health, sleep, and working from home. COPs also set up flexibility plans allowing clients and users affected by unemployment or income cuts as a result of the economic effects of COVID-19 to postpone his monthly payments. The hospital launched a psychological support program for professionals working in the front of the COVID-19 to provide them with the tools to manage the emotional stress generated by the emergency and protect their mental strength. And SPRI COPs also joined forces with other Spanish firms to protect the healthcare workers fighting coronavirus by contributing to the Solidarity Fund set up by the insurance sector to cover them and their families. And the last of the items is some questions to reflect upon. While other countries recently suffered other coronavirus epidemics, such as SARS or MERS, in most European countries like Spain, we did not face a pandemic since a century ago. We were not used to confronting it, and we were not well prepared to tackle such a public health emergency. There was an acute shortage of medical equipment and facilities. More trained professionals and critical care physicians were missed. Even simple materials as face masks were challenging to obtain. As the pandemic progressed, delivering this product to hospitals and clinics should have been a coordinated response in a matter of days. Instead, the medical infrastructure was not able to respond quickly and adequately to needs? And the answer is, why weren't we not prepared? Every country, hospital, enterprise learns its strengths and weaknesses in this kind of situation. What those of us in the medical profession have learned from the COVID-19 crisis has been dismaying in several fields. Medicine is a complex web of systems and processes. It's a healthcare delivery system providing treatment to patients. It's also a research program guiding discoveries from the lab to the patient bedside. It's a set of protocols for quality control, from clinical practice guidelines to drug and device approvals. And it's a forum for exchanging information, allowing for a continuous improvement in patient care. In each field, this pandemic has revealed some strengths, including heroism, but it also has exposed points of weakness. Systems that we thought were self-regulating, self-correcting, like a human body in good health, turn out to be exquisitely sensitive to turbulence, like the body during critical illness. On the other hand, it seems that a slow response might have led to a quick spread of the outbreak. Did we have our confidence at the early stages? Did we underestimate how the virus could push healthcare systems to the collapse? Did information circulate on time? What's more, it was known that SARS and MERS were deadly coronaviruses with animal reservoirs that could hop to humans. Disease modelers had determined that a respiratory virus with modes of transmission like SARS-CoV-2 was likely culprit in a future pandemic. Why wasn't our research investment remotely commensurate with our threat assessments? Another question is about if the informal transmission of the findings is part of medicine. It isn't what anyone is taught in medical school, but this continuous share of clinical knowledge that can be updated minute by minute is a gold standard due to the pandemic, when time is essential and you don't have time to research. The way in which doctors have used social networks during this crisis has been an encouraging development. We have created an informal medical bulletin board for the pandemic. And now everybody asks, when will things get back to normal? But me, as a physician, I fear that the resumption of normality will signal a failure to learn. We need to think not about resumption, but about revision. Now that in many countries, the life is slowly getting back to normal or to the new normal, the major potential danger is new outbreaks. It's essential to reinforce the international collaboration and strengthen world organizations like WHO to give a coordinated and consistent global response to potential new outbreaks or future similar health emergencies. And that's all from Madrid, Spain. Greetings from here. It's a pleasure you having me here. Thank you for all.
Thank you, Carlos, for that very clear and also moving presentation. As I said, different countries all over the world going through very different epidemics, but definitely very, very trying. And I really note particularly how complex the whole issue becomes. You refer to the human body, which is indeed a very complex system, but perhaps even better developed than human systems of community and society and governments and people. So thank you very much for sharing. Now I'll invite Katerina, who is going to speak to us about innovations in health promotion and particularly talking about a youth hub that will be launched soon. Katerina?
Thank you, Bernard, and good afternoon, everybody, and thank you for joining us today. I think using technology not only in the pandemic for connecting with your families, but also with your colleagues for being able to deliver the work and speed up processes, it's a great innovation. And I think within the Alliance for Health Promotion and also within my organization, which is Health Nexus here in Canada, we've been thinking a lot, and we've been thinking for a long time already. So I hope you'll be able to see on my slides and I'll be talking you through. In 2019, November, the Alliance for Health Promotion has been organizing the 9th Forum for Health Promotion within the WHO premises. And Health Nexus held a presentation regarding the leverage of technology to scale up health systems. And I can tell you that within Health Nexus, we are very proud of being digital. We are very proud of being connected to the world, not only by digital means, but also to our colleagues. And I can say that since the pandemic started and we've been sent home to be safe, we've been connected to our colleagues through internet, through this cloud, through SharePoints and other softwares that are basically helping us to be connected on a daily basis. In January, you have seen also that COVID-19 has been declared a public health emergency on international concern. In February, the Alliance held consultation with the WHO. And we've been talking a lot about how do we connect the youth, how do we work with the youth, through the youth, and how youth is a key population in the world. In March, COVID has been declared a pandemic. And this is why we thought with the Alliance, but also with other members and with our partners, that it would be great to kind of think on how we could be making this youth hub even more lively. We've come up together with the Alliance and with Health Nexus and with other partners with the initiative. It's called Youth Hub, and we have 2 specific streams. The first is called the School Project, and the second one is the Youth Hub for Young Professionals. We've been looking at different streams, and you also know that digitalization and innovation has been sped up. Everybody has been sent home. Your unique tools became basically your phone, your computer, and the internet, and the connection you have through these means with the entire world. Working from home has become the new normal for everybody. And it's been a digital, but also a very, very speed process. We've been consulting with youth organizations. Some of them you have heard from them today, and their consultation have been very, very valuable to us because we've been able to pick up on their needs, but also making sure that we hear their voice and their advocacy. On the School Project, which is going to be a project that will be taking and starting in Switzerland, we will be looking at awareness around health promotion, on emergency settings, and around pandemics. Within the Youth Hub, we will be working as a working group, and I can tell that we've been also interested in innovative ways. Our interactions are going to be online through collaborative platforms. We will be looking at mentorship. We will be basically bridging the gaps between experienced professionals and youth. We'll be obviously looking at health promotion, concrete proposals and awareness about health, but we could be also linking it with other global issues which are emerging and are also important at this time. We are also going to have an international network, which is going to be connecting through awareness and information and ideas globally. But we also want to be inclusive and making sure that all communities are represented and heard. We've been hearing the WHO at the consultation in February, and we will make sure to deliver on the issues and on the calls that we have promised to deliver on. And we will be consulting with the WHO, making sure that we are hearing their needs. And last but not least, we are committing to deliver our work, but also making our voice heard at the 10th Global Conference on Health Promotion in 2021. Thank you, everybody.
Thank you, Katerina. And that is a very good step. We have talked a lot about youth engagement in health promotion before, but now here you have a tool and also a strategy to move that to the next level. Wish you the very best, and we'll all support you and work with you to see that it does really bring fruit. Now, our last presentation is from Letitia van Haren of Mother's Legacy Project, and she'll talk to us about some work they've been doing during the pandemic. Letitia, are you still there?
Do you hear me now?
Yes.
Okay, so good afternoon, everybody. I'm going to be very brief because, so I am at the moment working. I founded an organization called SAFA, Smart Access to Health for All. And this is a pun on the smartphone, trying to get applications, smartphone applications that could be used by vulnerable populations, rural people, by everybody always forgotten, to bring them health literacy that matters, to empower them to manage their own health, but not just with information, but to give them a tool for contact to quality care. So it's not only just giving them a tool to learn, but a tool that helps you pick up the phone and get in touch with service that matters, service that's good. So behind it, there's also the challenge to bring the supply and the demand closer together, to make the demand, in our case, the pregnant women, understand why a certain type of help or treatment or checkup is necessary, and the health providers to understand why there can be reluctance and distrust from the part of the mother and her community. Now, while we are doing this in Bunda with the first effort, the first introduction of our smartphone application, Jumbo Mama, I also try to make sure that the population, from the health staff to the community health workers, gets updated information about the latest international health news. So when the COVID-19 virus started to spread, we knew that in those remote areas, nobody is going to give them updated, correct information that is neither excessively panic producing nor undercooled in the sense that it is not sufficient. So I made an effort to go through all the information that is available, and as a tentative worked out 2 fact sheets, one to protect pregnant women from coronavirus in rural communities in sub-Saharan Africa, and the other one especially about pregnancy and breastfeeding in a slightly different approach. The point was not to give something ready to use, but to give community health workers and first-line healthcare providers the opportunity to learn something that could sort of suit their situation, give them a comparison that is understandable from the rural area from where they are, with advice that was doable in the circumstances. Now, the last information I got from our team in Bunda is that they held another clinic, an outreach clinic, and that they included a demonstration and explanation about the COVID-19 virus and what the women could do. So the change from this one last leg that we forget, from the home where the people live, to the first step to get in touch with the healthcare provider, this is where I want to work. It's like very minute work. It's not easy. It is not always very statistically easy to prove anything, but I believe that it's necessary. Why am I doing this? Because I'm a cultural anthropologist and I've been involved and completely fascinated from, I think, from when I was a young child, and therefore chose this. And because even though there is a lot of lip service to the use of cultural anthropology, in practice, I see the big organizations choose social anthropologists and ask to produce statistics. But before we reach a statistical relevant number, we have individual families. We have to understand how the people function, how they work, how we can connect them to the modern world in a way that is not diminishing, not vilifying, not humiliating, but that is empowering. So this is the only thing I try to do. This time it was the COVID virus. Sometimes it is about, let's say, dental care. It can be about anything. If I am in touch with people and I know that this is an issue, I read about it. I read the international information from WHO and others. I try to condense it in something that is easy for them to use, and then they can carry it further or come back to me. So this is just my contribution to health literacy, and it's not yet on a huge reproducible level, but it's something that we as individuals can also do with the personal contacts that we have, and that we can then put together and work it out into something more easily multipliable. Is that clear? I hope. Thank you.
Thank you, Letitia. Very, very interesting and innovative initiatives. Really amazing. Thank you. I want to thank everybody. We've clearly overshot our time. I just want to close by saying, first of all, that think about the very many important strategic issues that have been raised by the different presenters, beginning with our keynote and our respondent, and then the different presentations. See how we can put this on the agenda. Some of them you can communicate with the Alliance, and we see how we can work on them together. My second message is really build on the lessons which you've learned during this period of COVID-19, but also build that into the future so that it is something that really goes beyond an epidemic and actually becomes something that can contribute to general health promotion in overall global development. Of course, we now see that it is, we knew all the time, it is not only SDG3, but actually all the SDGs. And that's why you hear about all of society approach, health in all policies, and now health is development, it's an objective. And earlier on today, I think Professor Kokenyi mentioned health is political, in addition to the other transitions which Dr. Kresh was mentioning. So really build on that and build that into broader agenda. And lastly, really, I can see very clearly that we need to share more. Just sitting here for 1 hour and a half and listening and talking to everybody, you can see how much there is. And so please, whether it is through the Alliance, we can help you to connect, or just between each and one of you, please share, share, share. I think we shall be stronger that way. And now it's my pleasure to close the webinar. Thank you, everybody.